Chapter 24, MIS Surgery. Objectives and terms. Minimally invasive surgery is performed by inserting instruments through a small or narrow incision in the natural body hole. MIS surgery is performed using a rigid lens, telescope, and long instruments. The inside space may be enlarged with fluid or carbon dioxide. Some endoscopic procedures do not require incisions because the endoscope is introduced through a natural orifice. Examples of endoscopic procedures not requiring an incision are bronchoscopies and colonoscopies. The goal of MIS is primarily operative rather than diagnostic. The cannulas protect the body wall and also maintain a seal between the inside of the body and the outside environment. Patients undergoing minimally invasive surgery are able to resume normal activities sooner, and the hospital stay is shortened. Many MIS surgeries are performed on an outpatient basis. Some disadvantages are patients who have had previous surgery have a good chance of having adhesions, which is scarring of the organs that causes adherence to the peritoneal wall, which makes it harder to push the trocar through or gain access to the area where you're trying to work. Other issues are related to electrosurgical equipment, light sources, and lasers. Because the instruments are long and rigid and you're working through a port, leverage is an issue. The range of motion is limited and you can only pull up or down so far. You want to make sure that the camera lens is clear and the light cord is functioning properly. If the lens has scratches or the fiber optic light cord inside is cracked, the view inside the cavity will not be as crisp and will make it hard to see. MIS surgery requires long, delicate instruments, which are limited in their range of motion. Withdrawing and inserting them into body cavities can be awkward. Diagnostic endoscopies is performed using a flexible, semi-rigid endoscope. The lens itself has channels that you can insert small instruments through to take a biopsy. The purpose of MIS is quicker recovery time and less pain for the patient. The process is MIS surgery is started by using a Veress needle to insufflate the abdominal cavity with carbon dioxide. It balloons the abdominal wall cavity out so you have space to work. Then through incisions that are about 1 to 2 inches long, the trocar cannulas are inserted. The trocars come in two pieces, the obturator and the cannula. The obturator is removed to insert the long instruments. Once the trocars are in place, they are considered ports. Not only do they allow access for the instruments to enter the body cavity, but they also create a seal between the inside and the outside of the body. The process of insufflation is a penetrating towel clamp is placed on each side of the umbilicus and lifted upward. A small stab wound is created in the superficial tissue of the umbilicus and a Veress needle is pushed through. Then a 10 ml syringe of saline is attached to the needle to test for the precision of the abdominal cavity. Insufflation tubing is attached to the Veress needle and the abdomen is insufflated. Arthroscopy is MIS of a joint space, like the shoulder or knee. The space is filled with fluid rather than carbon dioxide, such as saline or water. During this procedure, fluid is constantly flowing through to wash away any debris from the tissue shaver. There are 5 different types of MIS surgery. You have multiple incision, which is the most common. One port will have camera access, and then you have other ports, depending on how many the surgeon needs for instrument access. And then you have single incision, where a large bore cannula is inserted through the belly button area, and through that one port up to 3 items, usually a camera and 2 instruments, are inserted. They use the belly button area because it's usually easy to gain access to the abdominal cavity, and this support stays maintained in its position pretty well. The only problem with the single incision is the tight working space. This procedure has been used for appendectomies and gallbladder removals. Video-assisted thoracoscopies. They allow entry into the chest cavity without having to remove a rib or spreading them. It's used for pathology of the thoracic cavity and the anterior thoracic and lumbar spine. The natural orifice transluminal endoscopic surgery is when you start through a natural body hole and make an incision to gain access somewhere else. And robotic surgery, which we'll get more into detail in part 2 of this chapter. But in a nutshell, the doctor is seated at a non-sterile console and controls the arms of the robot. During the procedure, either the SA resident or the fellow, along with the scrub techs or the sterile personnel in the room, to switch out the robot instruments and to perform the duties that the robot cannot sterilely. Patient positioning and prep is performed in the same manner for the most part as if you are doing the procedure open. This is done in case the case converts to an open procedure. The only difference would be tilting the table in Trendelenburg or reverse Trendelenburg. Preoperative preparation for a minimally invasive procedure follows the same or similar protocols as open surgery. Depending on the patient and the situation, sometimes laparoscopic cases go open. You as a surgical tech must keep in the back of the mind that this could be a possibility. When you receive your case card, it should come with both laparoscopic and regular instruments. When the decision to go open is made, it goes fast, and they're not going to stop working for you to get your instruments. This is where communication and organization comes into play. You have to be able to let the circulator know what you need while still working. The imaging system includes the light source, which transmits light through the fiber optic light cable, which is composed of thousands of pieces of glass or plastic fibers that are aligned in parallel longitudinal bundles. A surgical telescope, a camera head, which holds the scope, and the camera control unit, which allows for adjustment in the light intensity. As long as the light cord is connected to the scope, it does not get hot. But the light cord can catch the drapes on fire and should not lay directly on the patient. When you open the tray with the light cord, you want to visually inspect it for defects. You won't know if the light inside is damaged until you plug it in, and that's done sterilely. The rigid telescope is a lens that captures the image illuminated at the tip. It comes in 0, 30, 45, and 70 degree angles. Always hold the scope by the head, not the shaft. You can bend it. Use lint-free cloths to clean the scope so you don't scratch a lens. And the optical angle is the direction in which lenses are focused on the image. Telescopes are delicate and expensive, and it's the responsibility of the surgical technologist to handle and maintain the telescope. The video camera is what allows the surgeon to view inside without having to put his eye to the lens. Video chips are located in the camera head. Each chip represents a pixel. The clarity of the picture depends on how many pixels the chip has. The more chips, the clearer the picture. The components of the camera head are the scope, mount, or the coupler connect, which allows you to connect the scope to the camera and the focus ring so you can focus. All cameras must be white balanced before use. White balancing adjusts the light color to the other components of the system. Other parts are the video cables, which transmits the digital signal, the output recorder, which processes the signals and sends it to the monitor which shows the images, and the equipment carts. Usually the monitor and the video system is on a cart and rolled into the room for each procedure. There are different types of specialty scopes. For example, a resectoscope is a rigid scope that contains inside a cutting and coagulation instrument. It is used for the removal of tissue and is commonly used in GYN and urology cases to remove tumors of the bladder, uterus, and to resect the prostate. Specialty telescopes are designed to fit the anatomical and technical needs of the specific specialty. Features include length, diameter, channels for continuous irrigation, such as in arthroscopies, and electrosurgical capability. Single-use trocars are commonly used. Cannulas are designed to remain stable during surgery, providing a snug interface and system for retention in surrounding tissue. Because of the restricted visualization of the surgical anatomy, MIS can lead to inadvertent injury to tissues outside the focal area of the telescope. Tissue planes are expanded atraumatically in order to create a space in the surgical site. Some expansion techniques include insufflation, which expands the abdominal wall with CO2. CO2 is used because it's considered non-toxic and is absorbed by the body. The gas is warmed before it's insufflated to maintain the patient's core temperature and to prevent fogging of the lens. Continuous irrigation, which is used during arthroscopic cases. Some common fluids used are normal saline, mannitol, glycine, and isotonic electrolyte solutions. And then you have balloon expansion of tissue planes, as in the pre-peritoneal space or the inguinal area. During MIS surgery, depending on how big the specimen is that they're taking out, they may need to use a morcellator. Morcellation is a process that reduces tissue to pulp that can be suctioned from the wound. Another option is a tissue shaver, seen in endoscopic procedures. It's used to remove masses, polyps, and redundant tissue from the endothelial surface. The shaver suctions the small pieces of tissue into the cutting channel, where a spiral burr shaves it into small pieces. Larger tissue specimens are retrieved from the abdominal wall through a retractable tissue bag that has been inserted through one of the cannula ports. It's called an endocatch. The bag is inserted through a large port, usually a 12 or 15 millimeter. Once inside the cavity, the bag is deployed and the specimen, such as the appendix or gallbladder, is put inside the bag and then pulled through the trocar hole. Minimally invasive instruments are similar to those used in surgery. There's retractors, scissors, forceps, bipolars, and bovies. The chain of care starts before surgery and continues through the intraoperative and postoperative reprocessing periods. Electrosurgical instruments must be checked for breaks in installation. Even a small defect may result in an unintentional burn. All instruments must pass through a cleaning and terminal decontamination or sterilization process immediately after use. Like other instruments, you want to remember during MIS surgeries, as they pass you instruments back, you want to clean as you go. And all instruments must pass through a cleaning and terminal decontamination or sterilization process immediately after use. And then flexible endoscopies, or endoscopy, is for viewing inside the body passage or organ. It's introduced through a natural opening and advanced carefully, such as in a colonoscopy. It's used for biopsies and examinations. Since the endoscope and instruments often come into contact with areas of the body that contain a high level of bioburden, a systematic cleaning process is necessary to ensure patient safety. And the hospital policy for reprocessing endoscopes follows the Occupational Safety and Health Administration guidelines. Any questions?